Good evening, friends, colleagues, and those that we have yet to get to know. Welcome to what is the final BOFAS Virtual Journal Club of 2024, this time entitled Achilles Heels, Treatment and Outcomes of Insertional Achilles Tendinopathy. I'm very pleased to be able to welcome as our guest speakers tonight Sebastian Baumbach from Munich, from the Ludwig Maximilian Universität, and also Sunil Dhar of the Queen's Medical Centre, Nottingham. So welcome to both Sebastian and Sunil as our speakers, and as well to all of you at home who've signed on for this evening. We're following the traditional format. We have two papers for presentation. The first on patient-reported outcomes treatment and outcomes of insertional Achilles tendinopathy from Sebastian's unit, and then a second paper from Sunil on the Zadek osteotomy for refractory Haglund deformity. In each case, the paper will be presented by one of our fellows, specifically Dr. Bhavanasi and Dr. Gonzi, and then we will have questions from the floor and discussion. Please do submit your questions via the chat, the Q&A. There are no questions too foolish. We're all friends here, well, more or less anyway. I'd like to thank, of course, our two guest speakers, Sebastian Baumbach and Sunil Dhar. Also, of course, May Labidi from the IT committee, who's kindly supported and is running this event tonight, and my long-suffering co-chair, Nijil Vasukutty, who is once again going to chair the second half of this meeting. So thank all of you for your contributions so far. So I'm afraid that we have missed one slight trick this evening. Being the last one before Christmas, we should perhaps have gone a little festive, but I didn't think of that in time. So we don't have Sunil appearing in Lincoln Green for Nottingham or Sebastian in Lederhosen for Bavaria. But never mind, we will still have an excellent academic discussion, I am sure. So with one last thing before we can continue with the papers, for your feedback, please do fill in the survey, which will be sent to you as an email link, and that will then generate your certificate for attending this evening. So without further ado, I'd like to introduce a paper by Dr. Sebastian Baumbach of the Ludwig Maximilian Universität in Munich, which, by the way, is nothing to do with Ludwig, the Mad King of Bavaria, who built castles up mountains, although he's also Ludwig. This is a very different Ludwig, an ancient predecessor of his. Sebastian has many interests, particularly around trauma and sports injuries around the ankle, around the syndesmosis and the insertional Achilles problems as well. So Sebastian's paper will be presented by our fellow Bhaskar Bhavanasi. So let's, without further ado, move on to Bhaskar's first presentation.
Foot ankle surgery in United Lincolnshire Hospitals NHS Trust. Thank you for giving me the opportunity to present this topic in BOFAS Journal Club. Today's topic is patient-reported outcomes of surgically treated insertional Achilles tendinopathy. The lead author is Hubert Porter, and the senior author is Sebastian Felix Baumbach. This article is published in Foot Ankle International in 2021. Introduction. Incisional Achilles tendinopathy presents as a challenging condition with a complex and somewhat elusive pathology, making effective treatment difficult to achieve. Despite advancements in diagnostic techniques, the specific causes of symptoms often remain unclear in individual patients, adding to the uncertainty of treatment outcomes. Surgical interventions, including both open and endoscopic procedures, offer options but lack of clear consensus on which approach is the best results. Many experts currently regard open debridement using midline incision transacillary approach, that is MITA, as the standard treatment. This procedure, however, is not without its risks, carrying potential complications associated with its invasive nature. Current evidence. Existing studies examining MITA's effectiveness tend to have small patient samples, leading to inconsistent reports of complication rates and variable treatment outcomes. This variability points to a significant gap in reliable data, emphasizing the need for larger, more comprehensive studies to better understanding the true efficacy and risk associated with MITA for treating IAT. Aim of the study: to evaluate patient-related outcomes following the MITA approach and debridement of all pathologies in patients with IAT. Methods. This retrospective study, conducted at a single orthopedic center, included patients aged 18 years and older who underwent a standardized surgical approach for primary insertional Achilles tendinopathy between January 2009 and September 2016. The surgical technique was minimally invasive and addressed all identified pathologies. When more than 50% of Achilles tendon insertion was detached, refixation was performed. Rehabilitation varied based on the extent of detachment, with immobilization protocols lasting 6 to 8 weeks, partial weight bearing at week 3, and a return to normal footwear following immobilization. Patient demographics, surgical details, and complication data were retrospectively collected. While follow-up included patient-reported outcomes, that is PROMs, measured by 4 validated tools. Number 1, the Victorian Institute of Sports Assessment Achilles Questionnaire, VSAAG. Number 2, Foot Function Index, FFI. Number 3, the Visual Analog Scale, Foot and Ankle, VASFA. Number 4, Short Form Health Survey, SF12. The FFI was used as primary outcome with other prompts as secondary outcomes due to a non-normal distribution of FFI scores. Non-parametric tests were used with Bowen-Peroni correction applied to account for multiple comparisons. The results are presented as median and interquartile range IQR for prompts and mean with standard deviations for other data. Results. In this study of 118 patients, complications occurred in 14%. Primary minor surgical site infections being 75% and 32% reported issues with shoe conflict. The mean follow-up duration was 50 plus or minus 35 months. The patient-reported outcomes measured by Foot Function Index, FFI, showed significant improvements over time. Final follow-up FFI scores were available for all. Full recovery rates were 62% for FFI, 71% for visual analog scale foot and ankle, and 53% VSAAG scores. Body mass index, shoe conflict were the only factors that significantly affected the outcomes. Overall, patient characteristics did not significantly impact the extent of improvement. Discussion. This study evaluated the outcomes of midline incision transacillary approach, MITA, with complete debridement in treating insertional Achilles tendinopathy, IAT, in 118 patients with average follow-up of 4.2 years. Full recovery rates range from 53% to 71% depending on specific outcomes measures used. Post-operative shoe conflict emerged as the main factor associated with the poorer outcomes. that surgical infection did not appear to influence the recovery. Although other surgical techniques may reduce the risk of tissue conflict, they have not demonstrated better overall patient outcomes. Endoscopic methods, while less invasive, may not adequately address all the pathological issues related to IAT, despite some limitations such as the retrospective design and the absence of a comparison group. This study provides a valuable outcome data, representing one of the largest patient cohorts treated with MITA for IAT. In conclusion, the midline incision transarticular approach MITA was treating incisional Achilles tendinopathy resulted in favorable patient-reported outcomes in both 12 months and 4 years post-surgery. However, 47% of patients experienced some residual impairment, with postoperative tissue conflict being the main contributing factor. The findings suggest that developing comprehensive patient registries and exploring alternative surgical techniques may help improve outcomes for individuals with IAT. Critical appraisal. This study faced several limitations. The retrospective design restricted the ability to draw causative inferences and made it challenging to account for all variables that might influence outcomes. Conducting the study at a single center also limited the generalizability of results, as treatment protocols and surgical expertise may vary across different settings. Additionally, the options of a control group, such as patients treated with endoscopic methods or alternative surgical approaches, weaken the capacity of attributes observed. Improvements solely to the MITA techniques. The follow-up rate of 63.4% introduced potential bias, as outcomes may differ between patients who completed follow-up and those who did not. Although tissue conflict was identified as a key factor in poorer outcomes, it is unclear why this was only influencing factor. Further research into other potential anatomical or biomechanical contributors could offer more insight into residual symptoms and patient outcomes. Thank you.
Okay, well, thank you. Thank you very much to Bhaskar for that very thorough presentation, and I apologize to all of you for the slight technical problem with the sound at the beginning. I hope that's now solved. Certainly I could hear it the second time around. So a fascinating paper. I'll give the floor now to the senior author of that paper, Sebastian Baumbach from Munich, who will take us through his thoughts and initial reflections on that paper. And then we'll take some questions from the virtual floor. So if you do have any questions to submit, please pop them on the chat, and then we will put them to Sebastian. Thank you. Sebastian, over to you.
James, thank you so much. And thank you to BOFAS for giving me the chance to talk about our paper. First of all, I'd like to thank my co-authors, especially Hubert Herterer, the first author, Professor Walter, for the great efforts. It's always a team effort, and without the team, we cannot address any of these topics. I was asked to talk a little bit about the limitation, my thoughts on insertional tendinopathy and research in general. Thank you very much for the nice introduction of the paper. And when I look at the critical appraisal, I actually just took a screenshot to get it right. It was stated that the retrospective design obviously is a issue. It always is. It was stated that it limits the causative interference and makes it harder to account for all relevant variables influencing the outcome. So my approach to research in general is what I think is really interesting, especially with foot and ankle. Once you start digging into literature, you're going to find little we know. To more or less none of the things we are doing, we have really solid evidence. And at some point we have to start. And often a retrospective design is a good way to start. I think even in a retrospective design, and this is where I don't fully agree with the presenter, we can account for variables influencing the outcome. And I think we can even closely account for them as good as we can do with a prospective study. What we cannot do compared to a randomized controlled study, we have a way harder time to have equal cohorts that we can compare to each other. But still, having a retrospective study with a considerable amount of patients, I think, is a good starting point if we think about pathologies, if we think about our treatment, how we can improve it. We obviously have had a loss to follow-up rate of 33%. Again, that is a risk that might bias our research. It can either be that the very good or the very bad did not answer our questionnaires that we sent to them, and obviously we had no comparison group with which is a other problem with the study. To me, the major problem of that paper is that the patient cohort, or maybe that's due to the pathology itself, is heterogeneous with respect to the pathologies present. And there was no standardized conservative treatment regime. All of these patients were referred to the clinics due to failed conservative treatment by an outpatient orthopedic surgeon, and this initiated surgical treatment for us. Further points that might limit the interpretation of this study is that the refixation of the Achilles tendon was not standardized at the institution. Again, it was a single-center study, but a multi-surgeon study, and there, to a certain degree, we tried to standardize the treatment and the diagnostic. Obviously, they're not going to be perfectly the same. And for us, if you look at the biomechanical literature, if you detach the Achilles tendon for more than 50%, you're supposed to refix it because that's going to increase the biomechanical stability. Obviously, we did not quantify the degree of detachment. It was up to the surgeon to judge whether he or she would refix the Achilles tendon or not. Keeping that in mind, that having refixed the Achilles tendon, that would dramatically change our post-op rehabilitation regime. If we refixed the Achilles tendon, our regime would be a lot slower, would be more similar to a rather restrictive Achilles tendon rupture regime compared if we had not refixed the Achilles tendon. That would have made it a lot more progressive with the rehab regime. These are points I think we can discuss. And there's another point. If you actually look at the study, we had this pretty big cohort of more than 100 patients with a follow-up of more than 4 years, and of almost 80 patients, we actually had a longitudinal follow-up. And based on that cohort, we not only published one study, but we turned out to finally publishing 3 studies. This again is a limitation. You're more. It might be that I'm just a lazy guy, a lazy researcher. But at a certain point, when you do research and you try to answer different questions, you kind of run out of the scope for a single paper. And this is what we actually accounted. And one more thing that we actually looked into from that point of view, and as I said initially, my predominant motivation for research is that I see a problem in the clinics, and I kind of ask myself, do we have to do it that way, or are we doing it the right way in general? Or do we have to question our approach? And if you then start looking into literature, you're going to see little evidence is there. And I think this accounts for Achilles tendon, like insertional tendinopathy, more than to a lot of other pathologies. Only in 2011, Van Dyck actually started to classify IIT per the underlying pathology and subdivided the insertion of the Achilles tendon into 3 different compartments. That be retroaxillary, intra, and preaxillary. And in each of these compartments, you can have different pathologies present either on MRI or radiographs. These include pre- and retroachilles bursitis, partial tears of the Achilles tendon close to its insertion, intratendinous degeneration, bone marrow edema and a Haglund exostosis, dorsal spores, or intratendinous calcifications. All of these to different amount were present in our patients. On top of those parameters, there are various morphologic parameters that have been associated to IIT. For example, the Fowler-Philip angle, parallel pitch lines, calcaneal pitch angle, and the length of the calcaneus. But especially if you look at those radiographic measurements, they had become significant in actually one study, and that was the study introducing those parameters. In each and every other study, they did not turn out to be a significant influencing factor. And I think if we look at all of these parameters, and that was the scope of a second study that we did, we actually tried to see, does any of these preoperative parameters does have an impact on the actual outcome, on our surgical outcome? And actually, we assessed 13 different parameters, and none of them had a significant impact on the patient-rated outcome at any time. It actually didn't even have an impact on the preoperative values. When we talk about how to assess the patient-rated outcome, we always look at prompts. This is what usually is asked from us to do. We need to kind of measure the outcome, try to quantify it by patient-rated outcome measures. We actually had several patient outcome measures, and if you look at the study, we did choose one of the weakest prompts, if you look at how they're validated, on one of the weakest prompts as our primary outcome parameter. And that was simply due to the structure. At some point in the hospital, we've set the FFE as the standard outcome parameters. So that was assessed just on a routine base from every patient. And obviously for that was the only parameter we had longitudinal data of. So we did set this as our primary outcome parameter. The FFE is the VISA-FR is the best validated outcome parameter. On the other hand, if we look at those patient-rated outcome parameters, and that's independent within the foot and ankle batch of outcome parameters we have, for all of them we see a ceiling effect, and we have a problem discriminating the good from the very good, and this is why we get the ceiling effect. This is why we should test for normal distribution. And at least from my experience, these patient-rated outcome measures are never normally distributed. So we have to do non-parametric testing. We have to talk about the median rather than the mean. And due to the ceiling effect, if we only look at the average parameters, they usually look pretty good in the different studies. We're actually just now working on a systematic review looking at the long-term outcome, that be more than 10 years plus following ankle surgery. And you're just astonished on how good the outcome parameters are if you only look at the average. And this is why I think this is another nice twist we did to the study. We did not only look at the average of the outcome parameter or the median, we also tried to quantify how many patients did not reach levels that are considered physiological, so which had some residual impairment. And these were more than 1/3, like 40% of the patients had some residual symptoms. This is just important for us to tell our patients. The MITA approach, so addressing all of the pathologies present, at least in Germany, still remains the most common approach. On the other hand, initially I talked about the different radiographic parameters, the different pathologies that are associated to insertional tendinopathy. There's no way for us to tell which of the individual pathologies is actually causing the pain, because all of these pathologies individually are present in asymptomatic patients as well. So maybe the MITA approach by itself is just an over-treatment, because we simply attack everything despite we might not have to do that. And if we then look at the data and we see that complications, for example, did not have a significant effect on the outcome, but the scar did. That was the only outcome parameter that we could identify that maybe must make us rethink, is the MITA approach the right way, so addressing every pathology, or is the surgical approach just we did a midline incision right over the Achilles tendon, Is that the right approach? Should we rather go para-articular? There are Y-shaped approaches. There's also the Cincinnati approach, which I think only is partially comparable to the other approaches because you cannot address all of the pathologies. I think this would be a first start, James, on my perspective of the paper and insertional tendinopathy. I'm really happy to push the discussion further based on any questions that might be out there.
Sebastian, that's really helpful. Thank you. That's a very, very thorough review and reflection. So thank you for that, of your time. I think we would all concur that every time any of us delve into the literature, small heterogeneous groups, case studies, level 4 is about as good as it gets for the vast majority of things that we look at. So thank you for making us start. We do have a few questions, some of which you've sort of addressed. From Ben Hickey, how did your SF12 scores compare to the general population or a similar cohort of patients who didn't have surgery? Now, obviously, you didn't have a conservatively treated group in that because of the way the German system works. And just to explain to other UK people, if I understand it correctly, in Germany, a lot of orthopedic outpatients is done by orthopedic surgeons who don't then do the surgery. There's a sort of stage between general practice and hospital orthopedics as we would know it. So that's a way of managing things that we don't have here. Do you have any thoughts on the SF12s in Achilles tendinopathy in the general population, or is that entirely unfair in the light of your study?
I think that would be pretty unfair to rate that.
Okay,
to be honest.
Fair enough.
And I'm not sure that with at least post-surgically, those quality of life scores I think are always kind of hard to assess, because if you only have problems with your leg when you walk up the stairs, your general quality of life is gonna be fair. So I'm not sure whether the SF12, at least post-surgically, is this a fair parameter to measure.
Okay, totally good. And there was a question from our eminent Guildford colleague, Matt Solon, to ask to clarify the surgery. So exactly what was the technique? So it was a midline Achilles splitting approach.
It was a midline incision, transaxillary approach. We then would detach the Achilles tendon as much needed from its insertion, and then debride anything we could find. We would take away the Haglund. If there are any dorsal spores, any intratendinous calcifications, we would remove these. If we identify any area of severe of degeneration that we could visually identify, we would also debride that. After that, we would close we would suture the Achilles tendon back together if it had been detached more than 50%. And the surgeon had the feeling that he or she had weakened considerably the insertion. We would reattach it with 2 anchors. Otherwise, we would do a regular skin closure.
Okay, and that's actually the midline approach is what I normally use for doing this personally. Did you encounter much in the way of wound healing problems? You mentioned shoe irritation long-term over the scar, but what about primary healing, slow healing or delayed healing or infection?
We didn't assess that, but at least in the long run, this did not have an impact on the patient-rated outcome. And I think probably those patients who would have had a major complication, these as well as the very good ones, these might be the 2 ends of the scope that we are missing in retrospective studies.
Okay, fine. I think that's very reasonable. The further comment from Mr. Solon is, not this then maximally invasive surgery? I think unashamedly it is. It would be my understanding of your presentation so far.
It definitely is. Maybe, James, let me raise one point there, how we have changed our approach. I think the major issue we have with insertional tendinopathy is that we don't know what is the actually causing pathology. So ours go like with the next talk with a closing wedge osteotomy. I don't have too much experience with that, but what we usually do is when we have a patient with failed non-operative treatment for insertional tendinopathy of the Achilles tendon, we would tell them that we do a single shot injection at the insertion of the Achilles tendon with just local anesthesia. And if that works well, if that decreases the pain to a degree that the patient is sufficient, we would offer endoscopic surgery and just address anything in that area that we could address endoscopically, independent of whether we see a dorsal spore, if we see intratendinous calcifications, or degenerative changes within the tendon. Otherwise, we go full aggressive.
Okay, great. Have you thought about any other surgical approaches, posterolateral, anything like that? Or if you're going open, do you always stick to the midline?
We usually always do the midline. But as I said, that might be the problem. I'm trying to push more into endoscopic procedures. I think it's just way more beneficial to the patient. The rehab is a lot faster. And if it does fail, we still have the option to go for procedures. But maybe we have to rethink our incision, especially if we take into consideration that 1/3 of the patient is still suffering residual symptoms from the skull.
Okay. That's fine, Sebastian. We must move on. So thank you very much for sharing your time, your experience with us. Do feel free to stick around and join in the discussion for the next paper for Zadek. So I'll hand over to my colleague, Nijil Vasukutty, to introduce the second half of the session.
Thank you, James. Thank you, Sebastian. We'll move on to the second paper. This paper is on Zadek osteotomy. So the title is Zadek osteotomy, a good treatment for refractory Haglund deformity. This is from the Nottingham team. The senior author is Mr. Sunil Dhar. Sunil Dhar does not need any introduction in any foot and ankle circles in UK. So he's just retired after a long career in Nottingham University Hospitals. He was a past BOFAS president. I think it was 2010, if I remember right, that he was a BOFAS president. He's quite well published. He's, at least in this region, he's a go-to person for a lot of senior orthopedic surgeons with any problem cases. He's trained so many fellows who are all well-established consultants all over the country. This paper is being presented by senior registrar on the Welsh rotation, Mr. Gianluca Gonzi. So I'll hand the stage over to Gianluca, who will present the paper, and after that we'll have a discussion with the senior author, listen to his thoughts and reflections.
Good evening. My name is Gianluca Gonzi. I'm a final year registrar training in the Welsh deanery, and I'm interested in foot and ankle. I thank the Journal Club committee for giving me this opportunity to present in this evening's Journal Club on insertional Achilles tendinopathy, and I'll be presenting a paper on Zadek's osteotomy, a good treatment option for refractory Haglund's deformity, which is published in 2023 by a group led by Sunil Dhar. So background, this is related to insertional Achilles tendinopathy. This is a degenerative process involving the insertion of the Achilles tendon and can be associated with retrocalcaneal bursitis and often a heel prominence and Haglund's deformity. This can be found in up to 3 in 1,000 of adults and as high as 52% of male endurance runners. The treatment options predominantly non-operative in the form of eccentric Achilles stretching exercises and occasionally extracorporeal shockwave therapy. Operative strategies include soft tissue surgery in the form of Achilles tendon debridement, detachment, and occasionally an FHL transfer. This can be associated with relatively high complication. In a systematic review, this can be as high as 23%, and with a 3.1% major complication rate of Achilles rupture and deep infection. So Zadek's osteotomy was originally described in 1939 by an American surgeon named This is a degenerative process involving the insertion of the Achilles tendon and can be associated with retrocalcaneal bursitis and often a heel prominence and Haglund's deformity. This can be found in up to 3 in 1,000 of adults and as high as 52% of male endurance runners. The treatment options predominantly non-operative in the form of eccentric Achilles stretching exercises and occasionally extracorporeal shockwave therapy. Operative strategies include soft tissue surgery in the form of Achilles tendon debridement, detachment, and occasionally an FHL transfer. This can be associated with relatively high complication. In a systematic review, this can be as high as 23%, and with a 3.1% major complication rate of Achilles rupture and deep infection. So Zadek's osteotomy was originally described in 1939 by an American surgeon named Isidore Zadek. They originally described this for patients wearing high heels with what he termed Achilles bursitis, in which he proposed a dorsal closing wedge osteotomy over the os calcis. The effects can be summarized into three effects. By performing a dorsal closing wedge osteotomy, you reduce the heel prominence by tilting the posterior prominence anteriorly. This acts also by elevating the insertion of the Achilles tendon, similar to an effect by an Achilles lengthening, and is thought to reduce the impingement between the fibers of the Achilles tendon and the posterior surface of the os calcis. As part of my review, I've looked at some biomechanical studies, and in summary, there are three main papers that demonstrate this. And one study by Palas et al., a cadaveric study, a dorsal closing wedge osteotomy did reduce the retrocalcaneal pressure by up to 44%. It did reduce the posterior strain, the strain of the posterior fibers of the Achilles tendon, but this did not reach statistical significance, and it did elevate the insertion of the Achilles tendon by around 3.4 millimeters. A vertical stimulation study shows the radiographic, led by Cesar Netto et al., indicates the radiographic implications following the dorsal closing wedge osteotomy, in which the Fowler's Phillip angle can be reduced by 14 degrees and the calcaneal pitch angle by 4.6 degrees. Yves Tourner et al. In a clinical biomechanical study showed that ankle dorsiflexion can be improved with a dorsal closing wedge osteotomy on the os calcis by around 7.27 degrees, and they've also reduced the calcaneal pitch angle in their series by 5.5 degrees, and I've got the references below. So going back to the paper, this was published in Curious Journal in May 2023, in essentially a single surgeon series on their experience with Zadek's osteotomy for refractory Haglund's deformity. This involved 19 patients, approximately 20 heels. All patients in their study had 6 months of conservative treatment with modified footwear and physiotherapy. All patients were assessed with an MRI scan to exclude alternative causes of posterior heel pain. A lateral view weight-bearing radiograph was taken pre- and post-operatively, and the Fowler, Phillip, and calcaneal pitch angles were measured on the PAC system. The Manchester-Oxford Foot Questionnaire clinical outcome score was used pre-operatively, and the 12-month post-operative mark was assessed via telephone follow-up by the study authors, and the statistical analysis was performed with the student t-test and piercing correlation coefficient. Going to the operative description by the authors as presented in their paper, as an approach, an extended lateral approach to the os calcis was performed. The tendon of Achilles was not visualized or debrided, and the apex of the osteotomy was planned posterior to the attachment of the plantar fascia, in which two limbs of the osteotomy were performed, the vertical limb and second osteotomy around 10 millimeters from the vertical limb, and the dorsal closing wedge was excised, maintaining the integrity of the plantar cortex. This was then stabilized with a 2-hole 1/3 tubular plate. The post-op protocol was 6 weeks non-weight bearing in a plaster, followed by 6 weeks weight bearing in a boot, and then returning to normal footwear at the 12-week mark. Going to the presented results and their patient demographics, the average age was 53, with an age range of 24 to 74, with a male-female ratio of 7 to 12. There were no major past medical history represented by the authors, and the authors state that all patients were stated fit and well. And the clinical outcomes, as mentioned earlier, the Manchester-Oxford Foot Questionnaire was used, and the higher score indicates a worse outcome. And there was improvements in all domains from foot pain, walking, standing, and social interaction, with a total reduction points of 108. And the author stated there were no wound or any complications following the procedure. The authors also give us indications from the radiological outcomes and improvement in these parameters, with an improvement in the Fowler-Phillip angle and also the calcaneal pitch angle of around 1.3 degrees. In summary, this paper shows that the Zadek osteotomy is a safe and effective procedure for refractory symptomatic Hagnon's deformity. This is associated with low rates of inter- and postoperative complications, and patients had a sustained clinical improvement at the 12-month follow-up. The authors state that while an improvement in the Fowler-Philip angle does lead to patient-rated outcome measure scores, the authors state that the focus should be on the patient symptoms rather than radiographic measures. The authors also acknowledge a limitation of study with small numbers, and this is a single surgeon case series. Thank you very much.
Thank you, Gianluca, for the nice, concise overview of that. I'll hand the stage to the senior author, Mr. Sunil Dhar, who will give us his reflections of his experience and the paper. Thank you, Sunil.
Hey, thank you, Nijil. Good evening, everyone, and thank you, BOFAS, for your invitation, for choosing this paper. Thank you, Gianluca, for your presentation, and all the attendees, some of whom, of course, I know. So, look, this paper isn't scientifically, we all recognize, up there with the best. So it was a couple of trainees who wished to look at this aspect of treatment for insertional Achilles tendinopathy. And by the way, we seem to have far fewer numbers than the German group, certainly not in the hundreds. It is a condition that occurs less frequently than, say, Achilles tendinopathy, of course. Nevertheless, it's a condition that really has bugged me over the years in terms of how to manage it best. Just as a background, the midline approach with the Achilles tendon splitting approach was what I did for several, for the first decade of my practice as a consultant. And that was purely to debride a really nasty looking tendon with lots of new bone calcification and or calcaneal tuberosity changes. But I was never very happy with the outcome of that. And I think Sebastian's paper really bears that out. When you have a third or more patients actually struggling after surgery, it can't be a very happy place to be in. That was my background till I was introduced to the Zadek osteotomy by a friend and colleague from Zurich, Pascal Ripstein. And he mentioned this procedure way back in the noughties at a meeting to me and said that it's something that he's found that works pretty well for this condition. And we was really seeking a better alternative than having to take the Achilles tendon off. And of course, since then, I have been utilizing the Zadek procedure. So coming back to the paper, we had a couple of trainees who wished to study this in further detail. And one of the things I said, look, you're not going to find tons of patients with this procedure, but what may be useful is if you studied a group with TROMs before and after, then you might be able to get a handle on, do they actually do well? I know in my hands, I am much happier with this operation for this condition than anything else that I've tried, and you can prove it or disprove it, and so that's why we got, and MOX-FQ had just come in then, and so we started using the MOX-FQ for subsequent patients till the trainees left, and then they subsequently wrote the paper. So I think the follow-up is of about 6 or 7 years between the last patient that was done and by the time the paper was accepted for publication. So overall, this is just a reflection of how you can utilize a retrospective study, maybe to prove to yourself and to your general group the point that something that you believe in may actually have the results that you think are valid and that substantiate your reason for doing that procedure. it's also very true, and what Sebastian said earlier was that the pathology is complex. Insertional Achilles tendinopathy involves the tendon, the bone, and the other soft tissues around it. And I was always reluctant to operate on it with a view to how much can you take. It's not just a case of taking off the excess bone that's formed around there or a bit of diseased tendon, because the biology has to be much more complex than that to cause all of those changes. Very different to, as we know, to Achilles tendinopathy, which is limited to the tendon and maybe the paratenon and the surrounding soft tissue. So this insertional issue was always something that really bugged me. With the Zadek osteotomy, it was quite evident to me right from the start that if you took a wedge of bone away, which was superiorly based, then it actually reduced the bump at the back, which was one of the main issues that patients came with, because that was the painful bit, rubbing on shoes. And that was very obvious in the first few cases that I did, that bump was reduced quite substantially by moving the posterior bit of the calcaneum forwards. The other thing that was quite obvious was that you actually increase the dorsiflexion of the ankle. In other words, this resulted in a small lengthening of the Achilles tendon. And, you know, when you think about these things and you look at your results and you're happy that your patients are doing well, one of the reasons on reflection that we thought that the procedure worked was it reduced the tension on the insertion of the Achilles tendon. And that must be a factor, because there has to be something to do with the vascularity, with the tension at the insertion, causing all sorts of issues. And if you look at some of the MRI scans, you see the substantial amount of bony changes that occur at the insertion, sometimes within the calcaneum, a lot of bone bruising around that area, other than tendon tearing, etc. So having done a few of these, we then set about looking at where to place the apex of this osteotomy. And again, from the initial stages, it was obvious that the best effect on the posterior bump was when the apex was actually more posterior, i.e. towards the back of the heel, than towards the middle of the calcaneum. It also reduced the tension on the plantar fascia, so plantar fasciitis became much less of a problem. Fixation of the approach to the osteotomy is very straightforward, very simple. Doing the osteotomy, again, is an extremely simple thing to do. You take out a wedge, you can measure the superior amount of the base of the wedge that you need to take out, and then closing the osteotomy, leaving the posterior or the plantar cortex intact. You then just simply dorsiflex the foot, and the osteotomy closes very nicely, almost like a book. And then you fix it with a very simple fixation method that we had, a very cheap fixation method, which was a 2-hole third tubular plate. Latterly, we'd also introduced a derotation screw, because one of the patients had a fall and then twisted their osteotomy around. So we introduced a derotation screw for that purpose, which was just a cortical screw, a 3.5 cortical screw. And then post-operatively, they're in a plastic cast for 6 weeks, and they mobilize after that. If they need, they can. You can provide them with a boot if they struggle to mobilize. So overall, I think what the paper has shown that the PROMs are good on these 19 patients. Clearly, they're not the whole cohort of patients, but these 19 were studied by our 2 trainees, who actually then went on to write this up and submit the paper. And I think there is a place for this, because you don't take down the Achilles tendon. We've never actually exposed the insertion of the Achilles tendon in any of these patients. And they haven't come back with rip-roaring tendinosis or enthesopathies or tendon ruptures afterwards. Thankfully, we've not had any major wound issues with this approach, and or a problem with DVT stroke PEs following this procedure. So as things stand, for a clinical diagnosis of insertional Achilles tendinopathy, substantiated by X-rays and an MRI scan, this is our standard go-to procedure. Now, nothing follows your good results than long follow-up, and I've been doing this now for a very long time. And I remember last year when I was disappointed to see one of my original patients come back with quite considerable calcinosis at the insertion of the Achilles tendon following a Zadek osteotomy about, 15 years back. And at that time, we did take down, because the lump was so extensive and into the Achilles tendon, there was no way that we could have reduced it simply by doing a Zadek or repeating the Zadek. So we had to take the Achilles tendon off to remove that quite considerable amount of pain. And I've got it in one of my own presentations as a sequelae, a long-term sequelae, perhaps of the condition and perhaps even the procedure. So things of course are never perfect, but by and large, this is a procedure that does give patients good pain relief, gets rid of that posterior bump to a substantial extent, and its complication rates are completely within acceptable limits. So I don't know, as a journal club, as a paper, people can make up their own minds about how scientific the paper is, but as a procedure for this difficult condition, we've shown that patients actually do have clinical improvement. Thank you.
Thank you, Sunil, for that nice overview. Can I ask, you talk about your case selection. So you mentioned in your paper 6 months of failed and non-operative treatment. So is that non-operative treatment in your unit with your physiotherapy team? I ask this question specifically now because a lot of patients come to us from a variety of providers now. So because from the GP, they go to an intermediary like team, the MSK team, where physios treat them. Some of them treat them with just physios, some of them with orthotics, some of them with shockwave treatment. So they come to us after varying amounts of non-operative treatment from various providers. So it's difficult to standardize that, isn't it? Some of them come 2 months after the problem starts. Some of them come to us a year after the problem starts. So
yeah.
Have you...
So it's exactly the same in Nottingham as well. So patients came from all sorts of providers. Some of them we treated in our own unit, as you would, rather than send them off to for surgery. But a lot of them came after many more months of conservative treatment and having tried orthotics, shockwave, physio, etc., changing footwear, changing jobs even. So they weren't just particularly in the unit, treated in the unit. And they almost inevitably had quite substantial irritation at the insertion, big lumps at that area, and were struggling. A lot of them couldn't actually put their heel down completely, and a bit like osteoarthritis, they go through phases, some of them, and then they have a period where things are kind of more bearable, and the whole cycle repeats it. But most of them, in fact, in all of them, we wouldn't go straight to surgery, have had all sorts of conservative treatment. But it's interesting, how do you define the condition? The definition of this, including, dare I say, Haglund's deformity, where you get this large posterior prominence, base, and on the basis of that, all the radiological measurements have been done. Now, we didn't find a huge amount of difference in our pre and post-operative calcaneal pitch angles, and I can see why we didn't find that, because our apex was so far posterior that it wouldn't actually affect the pitch of the angle substantially. And the Philip-Fowler angle is prone to measurement error. In fact, Yves Tourne's XY ratio in my view, and certainly in my hands when I tried it laterally since its publication of measurement in our patients, I found it a pretty variable index to measure and base my treatment on. So we didn't measure that in our patients. So if you for the audience, I'm sure this is something that's gained traction laterally, and Eve gives a very good talk about it, about measuring the x length of the superior part of the calcaneum, and then the overall length of the calcaneum coming to an XY ratio, which then determines what sort of treatment he's going to give the patient. But again, that depends on how good your X-rays are and where you think the edges of the bone are, and that can be quite a tricky proposition to be accurate.
Like that, yeah. So I think that answers Mr. Hesham Osbar's question. I'll go to another question from the chat box from Matt Solon. So Matt Solon asks, is the term Haglund of any relevance in 2024? And he's picked up one of the slides showing a big spur, but possibly no true Haglund. And he's asking, is it relatively rare for a prominent calcaneal tuberosity to be the only or the main problem?
Well, I fully agree with Matthew in that when you find this prominent bit of the bone at the back of the calcaneum, we always excise it. So, through this approach, it's very easy to do. You just take an oblique cut through this bit, and that's not a problem. But it's not always present. And I think I agree with Matt again that slide which showed that huge amount of calcification around the back. Sometimes that can be the only visual pathology on an X-ray rather than a Haglund's deformity. I mean, the term Haglund, it's been described. People have used it over the years, so I don't see any particular reason to disregard it. But it's not inevitable that it's not the only pathology in there. That's the recognition that the pathology is much more extensive and much more biological than a simple mechanical irritation from a prominent bit of bone on the front end of the tendon. I think it's much more than that, which is why it's so tricky to treat by simply debriding that bone.
Yeah, thank you. Let me see with this no other questions. So again, can I ask regarding your approach, your incision? Has the extended lateral approach been your go-to approach for these cases? Because there's always been this question about, the problem of using this approach for calcaneal fractures. Most people after the HEAL trial, people are going away from the extended lateral approach and going to minimally invasive approach for the calcaneum. So do you still?
Well, I think it's very important to understand that this approach in a trauma patient can cause problems and has caused problems. But this approach in an elective patient shouldn't, by and large, cause problems. So I think they're completely two different things. So you can't blame an extended approach for if it's not used in the right scenario, in the right environment. It's a really good approach. What can perhaps supersede it is an MIS calcaneal osteotomy, and I think Anthony Pereira wrote a paper on that several years ago on MIS calc osteotomies, and I think there's a place for that. I'm also reminded of Paul Cook doing MIS calc osteotomies and getting a non-union. Now, you've got to really try very hard to get a calcaneal osteotomy non-union. It's a bone that wants to unite, and as long as you fix it properly. So for me, in my hands, this has worked really well. I think it's a pretty good approach. It's a pretty safe approach. But people who do a lot of MIS stuff, whether you can mobilize patients faster or not, I don't know. I don't like the MIS fixation of a calc osteotomy because you've got to go through the insertion of the Achilles tendon again to put your screws on, unless people have found other ways of doing it. I don't know, but I think it works.
Thank you. Thank you very much. I think we've had a very lively discussion with both the papers. We're just 5 minutes past 9. We had a slight technical hitches, so with a slight overrun. So thank you very much, Sunil, and thank you very much, Sebastian. I'll let James take over and close the session.
Okay, well, thank you very much to all of our speakers, to Sebastian, to Sunil, to Nijil for chairing, and to May for the IT. And once again, I apologise for our little technical hitches there. So there you have it, ladies and gentlemen. The hodgepodge for sort of the potpourri of insertional Achilles tendinopathy. Are you a Zadek osteotomizer? Are you a tendon debrider and splitter? Do you swing both ways? Maybe there's a role for everything. But you've heard it all here tonight. So thank you to our senior authors, to my co-chair, to May. Thank you particularly to our two fellows presenting, Bhaskar Bhavanasi and Gianluca Gonzi. And of course, thank you to all of you for joining us this evening. I hope you have a good evening. And we will see you all again, I hope, in 2025. So thank you very much and good night. Just the final thing is do fill out your survey and then you'll get your certificates. But probably no Christmas cracker or special present under the tree. Take care. Thank you very much.
Good night. Thank you very much.